the uric acid, which can form crystals. And we need to decrease the sodium bicarb. And if we had to, the last resort is hemodialysis if they're in renal failure. For the leukemia, she said that the only one we need to know is AML.
Okay.
So
Let me go there. Give me 1 minute.
okay.
Okay.
Okay, are you good?
Yeah.
So with AML, it originates in the bone marrow and it has an acute development, so it can develop in just 2 weeks. The first basic treatment is going to be the induction therapy and also the stem cell, the HSCT therapy is also effective. With the complications, they can have pancytopenia and neutropenic infections. And we need to know the post bone marrow care is going to be apply pressure to the site, prevent infection, and assess for pain and bleeding. I feel like there's a question about this, but I don't remember.
I think
it was about applying pressure. It was about applying pressure after, something, but that's what it was. I remember it because I studied that one really well.
Good.
And I looked on the platform. There are things.
Yeah.
Okay. And the specific what they want us is just review very cautious the clinical manifestations, which means clinical manifestation of acute myeloid leukemia, which means that focusing on the signs and symptoms, actually, And then she told the nurse process.
The nursing process for the bone marrow transplant, you think?
No, the nurse, according to them, it's the nursing care. No, where is it? The nursing process, the patients with acute leukemia, page 978. And you have the assessment, you have the, I know it was a question regarding the mucositis. I think there was one, then you have to take care of their mouth care and the GI.
Oh, okay. Yeah, I see that now.
Yeah, you saw it?
Yes.
I don't really remember
I have it.
exactly.
Okay, so I have it right here. It's the nursing goals and patient care for acute AML. So it's managing and preventing infections, managing mucositis, improving nutritional intake, watching nausea, vomiting, and decreased appetite, easing the pain and discomfort, decreasing fatigue, maintaining electrolyte balance, improving self-care, managing anxiety and grief, encouraging spiritual well-being, and promoting home and community-based care.
Yeah.
Okay.
Yeah, that one was.
And then with the post-care for bone marrow aspiration, apply pressure, limit activity and strain, so they need to be on bed rest, and then watch for signs of rejection, which is the graft versus host in the venous occlusive disease. Okay. Then we have the Hodgkin's and the non-Hodgkin's lymphoma. And with the Hodgkin's, we're going to have the Reed-Sternberg cells. And it's going to be an enlarged one or more lymph node in the neck. It's going to be painless and firm. And then with the non-Hodgkin's lymphoma, it's more common in older people. And it's the B symptoms, the unexplained fever, night sweats, decreased appetite and weight loss, lymph, I don't know how you say that. Yes, and fever.
You can have B symptoms with both of them. And was a question in the exam regarding the B symptoms, which are the B symptoms, and will be select that all apply. And
Yeah.
was the fever, sweats, and weight loss. And they mention a lot B symptoms. Then I think she will be a select that apply.
I think so too. And then with both of the lymphomas, you can have really sore mucous membranes. So you're going to do good oral care. You can use the magic mouthwash. They need a bath every day because they're at risk for infection. And you can trend their labs. And the treatments that help are corticosteroids, chemo, radiation, and stem cell therapy.
And I think was a question, I don't really remember exactly, but I think was a question about lifestyle habits to avoid the second malignancy, because both of them are risk for second malignancy. And we have to study the nursing management. And the lifestyle was no alcohol, no smoking, good nutrition, exercise, and lower the BMI.
Okay, no alcohol, no smoking. What do you say one more time?
Good nutrition, exercise, and lower BMI or normal BMI.
Okay,
Okay.
thank you.
Because the nursing management, it's on the list here.
Yeah,
Yeah.
I know it gets hard, like combining all your notes. That's the part where I have stuff in different places.
Yeah. Yeah. Go.
Okay, so that's all for module 2.
Okay.
So now we're on module 3 stuff. It drives me crazy that they don't put it in order that they taught it too, because I have to find it. So we can start with breast cancer and the female reproductive stuff. Okay, we'll start with the female reproductive disorders because I had those first. So just the real basics. She said not to really worry about the STIs because she said she would do a really common question. So just know that HPV is the warts with no cure and it can lead to cervical cancer. So get the pap smear and the vaccine at 11 to 12. The HSV2 is the same as herpes. So I didn't know that. I messed that up.
And was a question about cervical cancer with the HPV?
There was a question, is that what you said?
Yeah.
Yeah.
Was a question.
So the HSV2 or the herpes is a recurrent lifelong viral infection. It's contagious. There's no cure, but we can treat with antivirals. And then gonorrhea and chlamydia are very similar. They can both lead to PID, infertility, ectopic pregnancies. The treatment is antibiotics. And then Ms. Jones pointed out that PID is a symptom, it's not a disorder. So it's actually what happens because of gonorrhea and chlamydia and other things. And for PID, we're going to use broad spectrum antibiotics in a combo. We're going to teach them that it can't reverse the damage to their reproductive organs. And the signs and symptoms are pelvic pain, low back pain, nausea, vomiting, and anorexia. Okay. So then the cervical cancer, the risk factors include HPV exposure, poor nutrition, chronic infections, early childbearing, sex at a young age, multiple partners, smoking, and family history. We're going to teach preventative, pap smear, vaccine, weight loss, and nutrition. And then the good treatment here is the radiation because it's the inner cavity. So we need to monitor for a dislodge, don't touch, use the forceps. Also, we're going to put them on a low residue diet to prevent a bowel movement, and we can give an enema before they place the radiation. This is the brachytherapy. They're going to limit their position changes, be on bed rest, and use a Floyd catheter while they have the brachytherapy in them. Care for the patient undergoing a hysterectomy. We're going to assess for signs and symptoms of a hemorrhage, which would look like low blood pressure, tachycardia, a weak pulse. We're going to call the doctor if they're bleeding, if they have fever, pain, or abdominal distension. We're going to teach them no lifting, driving, exercise, or sex for a period of time. I didn't write down how much time.
And I think was a question and was focusing on anxiety, but I don't really remember.
Yeah, that was one of the, it was like the nursing diagnosis was to like help with their anxiety and their body image.
Okay.
Okay. Oh, yes. And for the radiation patient, maybe this is one I missed. We're going to give emotional support because they'll be in isolation.
Mm.
So that was the other one for radiation.
That's good.
And then with the hysterectomy, we have the two different types, the total and the radical. And there's 3 different approaches. So they can take it out laparoscopically, vaginally, or abdominally. And the abdominal one is going to have a lower abdomen incision, so it's greater risk for infection. The nursing diagnoses for the hysterectomy are anxiety related to the diagnosis, pain related to surgery, risk for infection related to the Foley catheter, chemo, and surgery, and a risk for bleeding. Then the complications of a hysterectomy include bleeding, peritonitis, decreased urine output, bladder dysfunction, DVTs, and a vaginal hemorrhage.
Mm.
That's all I have for hysterectomy. For breast cancer, let me double check what I had here. Okay, the breast cancer, we're going to start with assessment. So we're going to do inspection, palpate, and check the lymph nodes. We're going to look for changes in color, thickening, edema. That could be orange or pale. They can have large pores. They can have an immobile mass, swollen nipples, and discharge. The diagnosis includes a mammogram, which we're going to teach to start at 40 and older. The breast self-exams 5 to 7 days after their period or after menopause to pick 1 day per month. The risk factors for breast cancer are the BRCA1 and 2 gene, if they're female, ages 50 to 69, obesity, alcohol 2 to 5 times per day, early menstruation and late menopause, and nulliparity, and late maternal age of the first birth of their first child. And I have HRT, but I have no idea what that stands for.
I think one of the question was about the lesions, non-tender, fixed, hard, with irregular borders, if I remember.
Okay, so breast cancer, it was non-tender, fixed, and hard.
Yeah.
And then the HRT is hormone replacement therapy. That's what I have.
Oh, perfect. Thank you. Fixed, hard.
Oh, and about lymphedema, one of the complications was, I think, was when she will be in the garden that she needs to wear the gloves, or if she was bitten by an insect, she needs to call. I don't really remember exactly.
Yeah, I think that was an evolved question. She had a
Okay.
mosquito bite on her arm, right?
Yes, okay.
That's the lymphedema. Then she said there's no evidence that smoking, breast implants, deodorant, wire bras, or abortion lead to breast cancer. There's no evidence.
Sure.
Then signs and symptoms. Oh yes, I also had the non-tender, fixed, and hard irregular borders. Okay, perfect.
Yeah.
Okay. Then the chemo meds that we can give for breast cancer are the tamoxifen,
Mhm.
which can then increase the risk of uterine cancer, DVTs, and PEs. And the first line of treatment is the trastuzumab, TRASTUZUMAB.
Where do we have it in the PowerPoints?
I don't know. I'm following off the study guides from before.
Oh, I see it.
Okay. So, and then concurrent with those are the three that start with, they end in the rubicin. So those are, it's the red devil is the doxorubicin or the daunorubicin or the idarubicin. And if they're on one of those concurrently, then they're at higher risk for cardiotoxicity.
Yes, that is, I saw it.
And then the post-op care for breast cancer, we're going to help with pain, comfort, positive body image, coping, and prevent injury. We're going to teach them drain care, hand and arm care. Watch for, oh, here's your complications, Maria, the lymphedema.
Mhm.
Report the insect bites, wear gloves in the garden.
Mhm.
Watch for hematoma and infections. And then with the drains, we need to teach them how to measure how much is draining, how to empty the drain, how to milk the clots out, when to call the doctor to remove the drain, and then any signs and symptoms of complications.
Mhm.
Okay, so
I think was a question about after the when you remove the breast regarding the exercise, but I don't really remember now.
I don't really remember either.
Yeah.
Does anyone remember a question about that for the mastectomy?
It was regarding like something about range of motion exercises or
Yes.
something like that.
Yes.
And it was that you're supposed to do them like, if I'm not mistaken, something like 20 minutes a day. And I can't remember how many times, but it was regarding range of motion exercises.
Yeah.
Okay, thank you.
Uh-huh.
Okay, so for the male reproductive disorders, we'll go into the prostate cancer. So I don't know if she's going to point this out, but it was in the PowerPoints. It's the acronym PLISSIT, and it stands for Permission, Limited Information, Specific Suggestions, and Intensive Therapy. So this is where you need to make sure you can talk about it with their spouse in the room.
But is that for the if you cannot have sex, like for the problem with the erectile dysfunction now, or with the prostate cancer?
Maybe I just had it in here right next to the male reproductive disorder. So maybe that's what it was for. Okay.
Well, maybe if she mentioned it, for sure we'll have it, you know.
Okay. Well, I think just know in general, men need someone with them at the doctor.
Okay.
Go with my husband to the doctor because he'll just sit there and be like, my life's fine. I'm like, no, it's not. That's why we're here. So they need women.
Okay.
Okay, the risk factors, she really pointed out the risk factors for prostate cancer. She's going to put the same question that she did before, that if normally you need to be screened for prostate cancer at age 50,
Mhm.
but if you have a family history or you're African American, you need to be screened at age 45.
That's true.
And she pretty much said that will be the question again.
Okay.
And then the other risk factors are BRCA1 and 2, if they're older than 50, if they eat a diet low in fruits and vegetables and high in excessive meat. The screening, you need to do the PSA first and then the DRE.
Yes.
And the signs and symptoms, they can have BPH, hematuria, dysuria, perineal or suprapubic pain, erectile dysfunction, incontinence, the hemospermia, rectal pain, and cramping. And she said that the prostate, it should be smooth and rubbery. So if there was changes there, then they could also go in. And the PSA is a tumor marker, but it's also a diagnostic screening tool. So it can be used for both. And
She specified the complication of the prostate cancer surgery can be incontinence, which can be temporary or permanent, and erectile dysfunction will be permanent.
what was the first word you said? Can be temporary?
Incontinence,
Oh, incontinence. Okay.
yes, and can be temporary or permanent. And erectile dysfunction, it's permanent if they had prostate cancer surgery. And she told us to review the education. Okay.
Okay.
Yeah. Oh, she mentioned the Lucron to know the medication. There are two medications, but only one I remember, Lucron.
What is the lucrum?
I don't know. I didn't get a chance to look into, but she told us to go on the, do you have the medication list with you, ladies, for this mail?
Yeah.
Oh, here, I have it. Okay. Yeah, Lupron. Lupron, and I'm not sure which one of these she mentioned again.
Can you
Prostar,
spell?
Lupron. Okay, and I think she mentioned the Prostar. Then you may want to look a little bit over them, just a little bit.
Thank you.
And I think there was a question about the Viagra, the sildenafil, one of the side effects, but I don't really remember which specific was, unless I will read it somewhere here.
So I think with those, we have to know that you can't take it if you have heart problems.
That's it. Nitroglycerin, the nitrates. And the question was, if take something with the nitrates, do you give the Viagra or something like that was a question.
Mhm.
Yeah.
There was another one on the Viagra, and it was where the man cannot get an erection, even though he was taking it. I don't know if y'all remember, but it was something like he goes back to the healthcare provider and he says, I've been taking my medication, I can't get an erection. And then it was a multiple choice. And one of them was like, and I got it wrong. That's why I reviewed it with her. And one of it was that it requires stimulation.
Yes, I remember that question.
Because I got that wrong. I was like, no, don't take, whatever. And she was like, no, it requires stimulation in order for it to work. And I was like, oh, I didn't know. I thought you just got like a 4-hour erection. She's like, no, that's a disorder. I was like, oh, okay. I didn't know.
I didn't know either. I guessed on that one. Okay, perfect. I think that's good. Then The management for prostate cancer, we need to know the TERP is the most common, and it can lead to erectile dysfunction. The complications of a TERP procedure include bleeding, clots. They'll need a catheter. Like Maria said, they can have erectile dysfunction, which is permanent. Incontinence can be temporary or permanent. We need to teach them, if their catheter gets a clot, how to manually get rid of the obstruction.
Mhm.
They can also have surgery, radiation, brachytherapy, which this was a question about. If they're having brachytherapy, they can't be around pregnant women or kids
Yes.
for 2 months. And but then I guess they can have sex if they wear a condom, is what she said.
That is it. You cannot be around him for 2 months, but then you can have sex with your wife with a condom. How much protection gives you? Something that
Exactly.
not make sense.
No, it doesn't.
The nurse goes in just quick and comes out quick and has to have the shield, but he can go home and you have sex with him. Come on, give me a break. Ladies, don't do it.
Something that I was reading on that TERP, they didn't mention it, but for some reason, I think I kind of saw it on the test. I don't know why. That one of the complications that could come from that is fluid volume overload, because sometimes, when you're irrigating, the client or the patient can absorb some of that water, and it could potentially cause fluid volume overload. And I don't know if that would make sense, but I mean, in a scenario, it might help you kind of figure an answer out.
I saw that one in clinical. It was with a woman, but they did the Murphy drip.
Uh-huh.
And it's kind of the same idea, but they hung 3 giant bags of saline, and they were all hanging on one pole, continuously going into her. So it's the triple lumen catheter, and they just pour it in, and that's when you put the chicken bucket under their catheter, because it literally pours out.
Oh, wow.
Yeah,
I didn't see that. I would have liked to have seen that.
Yeah, the color needs to be pink color.
Yes.
Okay.
And the blood clots need to be very small, right?
yes. If they're
Yeah.
big, you have to manually suck them out.
Yeah.
Yes.
And you speed up the drip also, don't you? Like if you're getting blood clots, you kind of flush it out with the IV.
Yes.
Okay.
If it's red or clots, you have to irrigate.
Yeah.
Yes.
Okay. And you have to give them soft stool softener
Yes.
after the surgery, and they will have bloody urine for 24 hours. It's okay, and then will be lighter as it goes.
Yes.
Okay, and just repeat what I have here. Okay.
And then also the PSA should start going down. And so if the PSA goes up, then we're going to look to see if the cancer has metastasized.
Okay,
Okay.
that's it.
Yep, I think that's it for that.
Okay.
All right. Do you want to go down to the genital urinary real quick, and then we'll come back to eyes and ears, because that's kind of out of order. Is that okay?
Okay, where do we go?
Genital urinary disorders.
Do you remember which medication was in the exam? The prostaglandin was a medication and caused tachycardia. And do you remember the name of the medication?
For which disorder?
I don't remember. It was for male disorders. Started with T and was a prostaglandin.
Prostaglandin or something?
Yeah.
I can go back and look, because I vaguely remember that.
Okay, then that's okay. I thought that somebody would remember.
Oh,
Okay.
sorry, it came unplugged.
Okay, we go to the urinary then.
Yeah.
Okay.
Okay, so for the general genital urinary, for the health history, we need to give them privacy, avoid medical jargon, and think about the effect on the quality of their life. So we need to know if they have a previous UTI history, fever, chills, dysuria, hesitancy, if they've been straining, had incontinence, hematuria, nocturia, or renal calculi. If they're female, we need to know if they're on contraceptives, how many pregnancies they've had, and also we need to know if they have genital lesions, tobacco, alcohol, or drug use. The common symptoms are going to be pain, voiding changes, and oliguria, nausea, vomiting, distension, diarrhea, unexplained anemia, which is caused because of the hematuria. And also because of the anemia, they could have fatigue, shortness of breath when exercising, and exercise intolerance. I need to go look through the PowerPoints. Does anyone have right in front of them the risk factors?
The risk factors for the lower UTI.
Yeah.
Okay, the risk factor is as we age, older men gets more than younger men. Inability or failure to empty the bladder completely. Obstructed urinary flow caused by congenital abnormalities, urethral strictures, contracture of bladder neck, bladder tumor, calculi, compression of the ureter, decreased natural host defenses or immunosuppression.
Thank you.
All kinds of problem there.
Okay, and then the physical assessment that we're going to do, we're going to palpate, look for distension, listen for bowel sounds, look for deep tendon reflexes, because we're looking if they have a neurogenic bladder. We can also check the kidney. You shouldn't be able to feel the kidney. So if you feel it, there's an issue. In the lower extremities, we're going to look for edema and fluid retention and observe their gait and balance. Then for the labs, we're going to do the PSA and the DRE for the men. And for the women, we're going to be watching for cystocele, pelvic prolapse, other structural issues, also adequate estrogen levels, and if they have lower back pain. She crossed out the VCG, so we don't need to know that for the imaging. We asked her in the review and she didn't know what it was.
Okay.
So you can just cross that out. For the labs, we have the UA, the specific gravity. So specific gravity should be 1.010 to 1.020. And IV fluids will lower the gravity and dehydration will increase the gravity. The creatinine and BUN will help us know the effectiveness of the renal function. And we know those should be 10 to 20, and then the ratio should be 10 to 1 to 20 to 1.
Yeah.
Then for the urinalysis, this is the most common. We're going to coca the fluids, check the pH, the specific gravity, look for protein, glucose, ketones, red blood cells, white blood cells, casts, crystals, and bacteria. And we do the urine culture and sensitivity to find out what bacteria is causing the infection. And it's often E. coli. For the diagnostic test, we can also do a renal function test. We can do the KUB, which she pointed out a couple times. It's the kidney, ureter, bladder imaging. We can also do the cystography, which is looking at the bladder structure.
Mhm.
And the IVP, the big thing to know about that one, she didn't tell us to cross that one out. So for that imaging, they have to have a catheter in to be able to do that imaging.
And check the allergies for iodine and shellfish.
Okay. Then we have the, let's see, I'm trying to like look at my notes and the blueprint because this is the part I chose not to rewrite it because it was just so much.
Yeah.
The biopsy is going to be the last resort. So that's how we're going to test the kidney. So they'll do the brush biopsy, the kidney biopsy, or a needle biopsy, but you wouldn't do it with anyone who has severe kidney issues or a bleeding disorder. And if you did have to do it, then you would increase the fluids. You would do bed rest for 4 hours, and you would watch for any signs and symptoms of bleeding. Then the patient prevention education. We're going to teach to avoid indwelling catheters, good care of the catheter, watch for any injuries related to testing, catheter placement, whether they're using a Foley or a straight cath, teach them. Medications, we're going to teach they need the antibiotics, the analgesics, and the antispasmodics. Teach them to wear cotton underwear, wipe front to back, showers instead of baths with no bubble baths, increase the fluids, and urinate after sex. A urine culture is a clean catch, not a cath. I think that was a question.
Yes, that's true. It's a clean catch.
Yeah, clean catch.
Yeah.
And then the lower UTI is going to be bladder and the ureter, and the upper UTI is going to be kidneys or pyelonephritis.
Mhm.
I really need to go back and study myself more about the urinary diversions. So I have that as my plan for tomorrow because I just really feel like I don't know enough about those. So if anyone does know and they want to talk about them, that's fine. Or we could skip them and just study them on their own.
Yeah. I think was a question about them. Okay. I remember one of them was a question. Okay. Sally told us to stay in, see if it's working, if it will put us back automatically in the meeting. Then I will
Okay.
now close it. Let's see what will happen, okay?
Yes,
Okay.
I think so.
Okay.
So I'm going to study them more, but she said to make sure that we know the Coke pouch and the
Indiana.
Indiana. So
And
I need to go back.
I think was the one about Indiana pouch.
Yeah.
Yes.
I feel like those just weren't covered very well on her
No.
recording, and I've listened to it twice now, and I don't want to go look in the book.